Correct.
And on the bottom of that, it gives you a date and time of that message, is that right?
Yes.
And the date and time, the date of that message is what?
April 11th, 2020,
And the time listed is?
12:46:19.
And is there a parenthetical there that has a UTC mark in it?
Yes, UTC -5.
All right, and the parenthetical of -5 means that UTC has been altered to get to the correct time zone, right?
Correct. It looks at the time zone of the phone, and it knows that our time zone is -5 or -6, depending on if we're in daylight savings time or not.
All right, and so, I'm sorry, the time on that message again was what?
12:46:19.
Okay, so that 12:46 represents Central Time.
Correct.
All right, and that's true for each message that would come through the phone in your report.
As if it's listed like this, yes.
I want you to turn here to the next page, and you see several messages there, correct?
Yes.
All right, and do each of those messages also contain a date and time stamp?
Yes.
And again, do those dates and time stamps accurately reflect Central Time?
All of them are listed as Central Time. Yes.
Yes.
Thank you. Let's put it up on the, almost so we can all see. All right, and what this appears to show is a message. Can you see it?
I have to look at the screen, yes.
All right, so we see initially,
Investigator, if you want to get up, you can look at that, the screen to your left, if that's easier.
what this would indicate on the top there is a missed audio call through Facebook Messenger from an Xavier Irizarry to Mr. Acevedo's phone, is that right?
That is correct.
And the date and time stamp on that missed audio call was what?
4/19/2020 at 6:15:45 a.m.
All right, and the next below that, you see what appears to be an actual Facebook message. Is that like a text message from Facebook?
Correct.
Okay, and it says yo, right?
Yes.
And what's the time under there?
6:15:48.
All right, and the green box on the right would indicate activity from Mr. Acevedo's phone, right?
Correct.
And that appears, well, it's a call back to Mr. Irizarry. That's what that indicates in the report.
Right.
For a period of 1 minute, is that right?
Yeah.
Okay. And what time did that occur at?
6:40:52 a.m.
And again, we see some more contacts that would appear here to come from Mr. Irizarry, is that right?
Correct.
A missed audio call from Facebook Messenger, what time was that and date?
Yeah.
And I'm sorry, the date and time?
The first one is 4/19/2020 at 7:00 p.m.
And that appears to be a missed audio call from Mr. Irizarry to Mr. Acevedo.
Yes.
And the next box, again, would be, again, a similar Facebook text message type communication from Mr. Irizarry's phone to Mr. Acevedo's phone.
Yes.
And that occurred at what time?
7:00 and 22 seconds, so 3 seconds after the audio call.
And then the last one we see there is another of these sort of text message type communications from Mr. Irizarry to Mr. Acevedo's phone at what date and time?
4/19/2020 at 8:04 a.m.
And it says, what happened? Oh, that's all I have for investigator O'Donnell.
Thanks, sir. Take a seat. State, Mr. Tiffin?
No questions.
Okay, well, Mr. Gosh, thank you. You're excused.
Defense calls Dr. Jimmy Valentine.
Doctor, right over here, please.
Do you solemnly swear that the testimony you give in this matter will be the truth, the whole truth, and nothing but the truth, so help you God, or under the pain or penalty of perjury? I do. Thank you. You have a seat there. Speak clearly into the microphone. State your name and spell it for the record.
It's Dr. Jimmy Valentine, and I spell my first name Jimmie. Last name is Valentine, just like Valentine's Day, Valentine.
Thank you, sir.
Sorry,
Mr. Powell.
Good morning, Dr. Valentine.
Good morning, sir.
Can you tell us what you do for a living?
I'm retired from the University of Arkansas College of Medicine in Little Rock, Arkansas. And since I retired, I do nationwide consulting in my area of expertise, which is clinical pharmacology and forensic toxicology.
Right. And can you describe for the jury what you mean by clinical pharmacology and forensic toxicology?
Sure. Clinical pharmacology is the study of drugs and how they affect the human body. While I was active in teaching medical students over my 30-some-odd years of career in teaching medical students, we taught sophomore and senior students in medical school about drugs, how they were used, the effects, the good pharmacological effects of them, and then also the effects that would be what we call side effects, or the effects that we don't want to typically see in an individual, or at least learn how to work around those side effects. Toxicology is the study of drugs and what it could be chemicals in the environment, whatever. The specialty that I hold is in forensic toxicology, which is the identifying of drugs in the body, in various body fluids, and what those levels actually mean in an individual, what effect they would have had in an individual.
Thank you. May I approach, Your Honor?
Yes.
I'll show you what's been marked as Exhibit 35. Recognize that document, Dr. Valentine?
Yes, sir. This is my curriculum vitae.
Fancy word for resume.
Yes, it's a kind of covers everything, hopefully, that I've done over the years, educational experiences and where I've been employed, publications, and so forth.
All right, well, let's not go through the entire thing, but let's give us a flavor, if you would, of your educational and professional background as it relates to the topic of your testimony today.
Yes, sir. I hold bachelor's degrees both in biology and chemistry from Centenary College of Louisiana, and then I hold a master's and PhD in medicinal chemistry from the University of Mississippi.
And have you been published in peer-reviewed articles and journals?
Yes, sir, I have.
What's a peer-reviewed journal?
A peer-reviewed journal is when we do research in your laboratory and you want the rest of the scientific and medical community to know about the research that you've done. What you do is you submit your work to a journal. You submit it to the editor of that journal, and then the editor of that journal will take your manuscript and submit it to two other people in the area that are, equivalent to you in their stature in the scientific community, and they're unknown to you. It's a situation where they are totally unidentified to you, and then they will review the manuscript, and they will give you one or three comments on it. They'll say that this is very important work, should be published forthwith in the scientific or medical literature. Or the more likely thing is they would say, you need to consider such and such in the manuscript, maybe do a little bit more on it, make a correction here or there, and then resubmit it for publication. The third is that the thing you don't want to hear, and that is that this is not worthy of publication in this particular journal. So that's what we call the peer review system. It's been the system that's been in existence in science and medicine ever since I've been involved in it. And it's a pretty good system. It works pretty well.
And have you testified in court as an expert witness before?
I have, yes, sir.
Approximately how many times?
I don't know exact number. I have been qualified, I think, now in 32 different states in the United States in courts as expert witness, and I've testified here in Wisconsin a number of times.
And have you worked previously as a forensic toxicologist?
I have. In the academic appointments that I had at 3 different medical schools, I always had a laboratory for forensic toxicology, which I served as the director of. The last one was at the Arkansas Children's Hospital in Little Rock, where I was the director of the toxicology, clinical toxicology services. We served both the Arkansas Children's Hospital as well as, to some extent, patients who were in the university teaching hospital, and we also did work for the Arkansas Department of Health.
And do you have experience in testing or analyzing controlled substances from human biological samples?
Yes. When we talk about running a forensic laboratory, that's exactly what you're doing. Is you're taking various body fluids, could be blood, urine, we call it oral fluid, could be hair samples, could be, in children we use meconium, which is the first little poop the baby puts out to analyze for drugs. So that's the basics of what you do in forensic toxicology. You analyze it and then determine what those levels mean.
All right. And you were asked to consult with us on a case involving a gentleman named Joel Acevedo. Is that correct?
Yes, sir, that's correct.
And we asked you to look at, well, what did we have you review?
Well, you asked me to review. I had medical records on Mr. Acevedo, and then I also had the both some antemortem specimens that were drawn on him while he was still living in the hospital, and then I had some samples that were postmortem samples as well too.
All right, and let's talk about that. So you mentioned some tests or some records from the hospital where Mr. Acevedo was brought while he was still alive. And did you see any reports regarding the collection of a urine sample and a subsequent toxicology screen done at the hospital?
I did.
And tell us about that particular result.
Yes, sir. There was a urine specimen collected on him as part of his clinical care. And let me just refer to my notes here, make sure I get the time right on this.
Let me do it this way. May I approach again, Your Honor?
Yes.
I'll show you what's marked as Exhibit 33, Dr. Valentine. This document looks familiar.
Yes, sir. Yeah, that does. Thank you very much.
What is that document?
This is the document from the Aurora St. Luke's Medical Center on the urine specimen that was collected on Mr. Acevedo, and that was collected on 04/19/2020 at 11:32 hours.
Okay, and that samples collection and the results of a toxicology screen appear on that document?
It is, yes.
All right, and what were the results of that toxicology screen?
The screen on this particular specimen was positive for cocaine metabolite, and that's what they're actually testing for is benzoyl-ecgonine, which is the major urinary metabolite of cocaine. And then it was positive for cannabinoids, that means marijuana. So that particular test tests for not only an inactive component, it tests also for some of the active components as well. And then it was also found positive for ethanol, and the ethanol level was 270 milligrams per deciliter.
Now, ethanol that's alcohol, correct?
Correct, yes, sir.
If you're consuming alcohol like beer or wine or liquor, your body will show up as having ethanol in its system. Is that right?
That is correct.
Okay. So the number you just told us about, 270, you said milligrams per deciliter?
Yes, sir, that's correct.
All right, so from a urine sample, is there an accepted formula for converting that measure of alcohol in the urine to trying to ascertain or estimate what someone's blood alcohol content would be?
You can do an estimation of what the corresponding blood level was at the time. We have to make some assumptions there. You assume again that the person what we call the post-absorption stage of the alcohol. In other words, all the peak has occurred in the blood, and now we're in the elimination phase. And if you make that assumption, then you can use, you basically divide that figure by 1.35, and that will give you an estimate of what the blood alcohol level was.
You used a couple of terms there. I just want to make sure we all understand. You talked about an absorption phase and an elimination phase, correct?
Yes, sir.
And does that mean if I've had a drink, the alcohol doesn't immediately affect me, correct? It has to be absorbed into the system and distributed throughout the body.
That's correct. If you drink alcohol on an empty stomach, what happens is that the alcohol is absorbed fairly rapidly into the body within 30 minutes to 60 minutes. Most of it will be absorbed in the body. You absorb about 20% in the stomach and about 80% in the first segment of the small intestine. If you have food in your stomach, then the absorption of the alcohol from the stomach and the small intestine is slowed down because of the competition with the food. And so that sometimes takes up to 90 minutes or maybe even longer, depending on how heavy the meal has been in a given individual. And so what we say is that is the absorption phase. In other words, the alcohol is being absorbed from the gastrointestinal tract into the blood. And whenever that's complete, and so again, depending upon whether it's food in the stomach or not, then you say that you're in what's called the post-absorption stage, that all the alcohol has been absorbed into the blood.
Then the body begins to eliminate it from the system, is that right?
Yes, it'll then be eliminated from the body through the urine. Some of it comes out through the breast, some of it can come out in sweat as well, too.
Okay. And so did you do those calculations on Mr. Acevedo's urine sample to try and get an estimation of his blood alcohol content at 11:32 in the morning that day?
Yes, sir, I did.
And what number did you come up with?
I came up with a 0.2 BAC. Now, again, that's an estimate.
All right, so not necessarily perfectly accurate, but it gives you a decent ballpark of where his blood alcohol content would be.
I think that's a good way to describe it, yes, sir.
Okay. And are you aware of the blood alcohol content limit for driving a car in Wisconsin?
Yes, it's 0.08.
And here, your estimation is that Mr. Acevedo was at 0.2, is that correct?
That's correct.
So again, it's an estimate, but that's about 2.5 times the legal limit for being able to drive, right?
Correct.
And that's at 11:32 in the morning.
Correct.
And so you can't tell us, though, because of the assumptions you have to make, am I right? We'll strike that. Let's talk about this. Is there a way then to estimate backwards to try and estimate or figure out what his blood alcohol content might have been 4 hours before that, say at 7:30?
Well, you can use what's called retrograde extrapolation to attempt to do that. In this particular case, that's not wise to try to do that simply because we have a lot of unknown factors. We don't know, for example, when he started drinking, when he stopped drinking, so we don't know that he was absolutely in the post-absorption stage when the incident occurred.
Okay. We can safely assume he wasn't consuming alcohol between the time he was taken to the hospital and the time the urine was drawn, right?
That's true, correct.
So, again, assuming that Mr. Acevedo has not consumed any more alcohol, is it fair to conclude that his blood alcohol level would not be any lower than 0.20 at 7:30, 4 hours earlier?
I think that probably would be a safe assumption.
Okay. And again, but based on the factors you don't know, you can't reliably extrapolate backwards to see what it would have been at 7:30.
That is correct.
Okay. Now, you mentioned some other substances that were discovered in the urine screen. And that particular document, Exhibit 33, just describes cocaine metabolites, doesn't give you much more information about that, right?
That is correct.
You were also, you also reviewed a document from the Milwaukee County Medical Examiner's Office, is that right?
I did, yes, sir.
I approach again, Your Honor?
Yes.
I'm going to show you what's been marked as Exhibit 14, Dr. Valentine. Do you recognize that document?
Yes, sir. Yes, I do. This is the toxicology report that was from the Milwaukee County Medical Examiner's Office.
All right. And that document gives you more information to work with than the urine screen from the hospital. Is that true?
It does, yes.
All right, and briefly describe for us what you see regarding the results of that toxicology report.
Yes, these are most of these are on what we call antemortem samples. These were samples that were drawn from Mr. Acevedo in the hospital. The first results they call screening results, and they screen these by a very reliable method. It's called liquid chromatography mass spectrometry, and it's very good for identifying compounds. They identified the inactive metabolite of the active ingredient in marijuana, which is carboxy-THC glucuronide. So this is the inactive constituent that's in marijuana. It's the metabolite of the active constituent, THC. They identified cotinine. Cotinine is a metabolite of nicotine, so it tells us that he used some type of tobacco product. They also identified ecgonine methyl ester. Ecgonine methyl ester is also a metabolite of cocaine itself. And then they identified levamisole and tetraamisole. Levamisole is typically a diluent or a cutting agent that's used in cocaine. It's a local anesthetic material, and so cocaine is typically cut with that. So when you see that, it means that you're using some type of a illicit cocaine. Then they reported also quantitative results for the ethanol, and they reported that as 0.047 grams per deciliter. And then there was a vitreous sample. This is the fluid from the eye that was taken post-mortem, and the alcohol was not detected in that sample. Then they also detected in the serum benzoyl ecgonine, which is again this metabolite from cocaine, and they detected that at a level of 740 micrograms per liter, which is the same thing as 740 nanograms per milliliter.
All right, let me ask you a couple of questions about those things. So there's an ethanol result here of 0.047. Do you know or do you recall from your records about when that particular serum sample 435666 was?
Yes, sir. That was taken much later in the day, and I believe it was about 1610 hours.
4:10 p.m.?
4 p.m., yes, sir. 10 minutes after 4.
All right, so I know you discussed earlier regarding the urine sample that there wasn't a reliable method to work backwards to 730 to try and estimate Mr. Acevedo's blood alcohol content there. The same factors hold true for that result, or can you do a calculation with that sample?
Yes, again, trying to do a retrograde extrapolation on this value that we got in the blood, again, is not wise because there's so much we don't know about what went on prior to the event. In other words, when the alcohol drinking started, when it stopped, what was being drunk, and so forth. So it would not be really wise to do the retrograde extrapolation for that.
Okay, you described for us earlier what pharmacology is, and it's your science of effects of controlled substances or drugs on the body, right?
Yes, sir.
And are you familiar with the pharmacology of cocaine and how it affects the body?
I am.
All right, and describe that for the jury, please, how one who's ingesting cocaine, how that would affect the typical person.
Cocaine can be abused in several ways. You can either put it in your vein intravenously. Generally, that's not the way it's used because if you snort it, pull it up into your nose, then that is about as effective as getting it, the blood level as giving it IV, because it gets into the nasal lining and that's absorbed almost immediately into the blood. Then cocaine can be smoked as well too, but again, the intranasal route is usually the route it's abused by because it's so rapid, the effect of it. When one uses cocaine by any of those routes, what will happen is that you'll get initial euphoria, and that's the reason people use the drug. They want this good feeling they get. What it does is it stimulates a release in the brain of a neurotransmitter that's called dopamine. And dopamine is considered the pleasure amine of the brain. It's whenever we have a good experience, we release dopamine in our brain. So that's what happens, that cocaine causes that release of dopamine in the brain. So the person gets this initial euphoria from the use of the cocaine, and that lasts about 10 minutes, sometimes is up to 30 minutes, depending upon the dose that the person has used. The concurrent with that is that you increase the heart rate. And so cocaine is a very potent cardiovascular drug. So what it'll do is it'll increase the heart rate, it'll increase the blood pressure. Generally, if you measure the blood pressure on someone, you would see that the systolic blood pressure, that is the top number on the blood pressure reading, goes very high. It'll go up to 160, 180 in the individual. The heart will be beating very rapidly in the individual. And sometimes it's a very uncomfortable feeling for a person. We know that certain people can get actually into coronary vasospasms, where they get like almost like a myocardial infarct that occurs after using cocaine. That's in a small subset of people that occurs.
Let me stop you there, doctor. I'm sorry. You said a myocardial infarct, I-N-F-A-R-C-T?
Yes.
And describe for the jury what that is, please.
That's where the coronary arteries, you got these arteries on the side of the heart that supplies the muscle in the heart with blood. They get clogged. And a lot of times they're clogged with cholesterol, and that's the reason people have a heart attack. But you can have a contraction of those when you use cocaine, and that'll cause a heart attack-like effect in the individual.
And can that happen through, does that require a very large dose of cocaine for that to happen?
It does not. It's individually related. It depends on the individual. Everybody handles drugs a little bit differently. So as you, in pharmacology and toxicology, as you increase the dose, the likelihood of these things occurring is greater, but they can occur at lower dose as well.
Okay. So is there, well, so you testified what you saw in the medical examiner's toxicology report, correct?
Yes, sir.
And did you also look at some other documents we obtained from the toxicology lab, runs from the machines when the toxicology lab ran this sample?
Yes, I received from the laboratory what we call a litigation pack, and basically that is all the analytical results that they had from the analysis they performed. And what we get is what's called chromatograms that come from the machines where the sample is processed. So I had all of those to look at as well.
And when you looked at those, did you see additional substances in Mr. Acevedo's blood sample that were not reported on the toxicology report from the crime lab?
I did.
What did you see?
I saw two other metabolites that one typically sees with cocaine use. One of them is what we call cocaethylene. And cocaethylene is a metabolite that forms only if you're using alcohol and cocaine simultaneously. If you use those simultaneously, you get this metabolite to show up. The other was I saw they reported the benzoylecgonine, but I also saw cocaine itself in the sample.
Cocaine.
Cocaine itself, yes.
So that would be cocaine that's not been metabolized in the body yet.
Yes. Let me explain what happened on this. But this sample that was drawn on Mr. Acevedo was a clinical sample. So it's not drawn like a forensic sample would be drawn. So it's what we call a serum sample. And the serum sample did not contain a preservative. It's called sodium fluoride. Without that preservative in there, what can happen is there's an enzyme in the blood itself. It's called acetylcholine esterase. That enzyme can metabolize cocaine to benzoylecgonine. Now, there's a limited amount of acetylcholine esterase in the blood, so it can't metabolize all of it, but it metabolizes some of it. And that's part of the reason we're seeing this benzoylecgonine metabolite, but also it was metabolized in his body as well. So we're having a combination of those two things.
Okay. And how quickly does cocaine metabolize into benzoylecgonine? Forgive my pronunciation.
You did it perfectly.
Thank you. How long does it take for the body typically to metabolize cocaine after ingestion into that substance?
The metabolism to benzoylecgonine starts forthwith in the body. Part of it's because what we just talked about, the acetylcholinesterase starts metabolizing it in the blood immediately. But once it goes through the liver's a major organ of metabolism, it'll start to metabolize the cocaine to benzoylecgonine. So you will see benzoylecgonine appear in the blood about 15 to 20 minutes after the dose of cocaine. It'd be real low amounts. And then it gradually increases and then reaches a plateau in the blood and will stay there longer. Cocaine itself tends to disappear fairly rapidly from the blood. Within about an hour to hour and a half, cocaine tends to disappear from the blood. So it's difficult to find it after that point in time. But the benzoylecgonine levels will go up in a plateau, as I said, and that'll stay there for about 6 to 8 hours in an individual. You'll see the benzoylecgonine, and then you'll see it even longer in the urine because it's being eliminated from the body.
Okay, so does the fact that there was still unmetabolized cocaine in the sample tell you or indicate that there was a fairly recent ingestion of cocaine by Mr. Acevedo?
Yes, that's what that would indicate, correct.
And let's talk about some numbers. Now, you said 740 micrograms, is that right?
Yes, sir. Well, they reported it as micrograms per liter, and that's the same as nanograms per milliliter as well.
Okay, and can you give us sort of a relative idea of, is that number big, is that number small? What does that tell us about, if anything, about Mr. Acevedo's ingestion of cocaine?
That number would be considered high. Anytime if you've used cocaine just one time, that's what we call an acute dose, you would expect the benzoylecgonine level to go up and plateau at about somewhere between 100 to 150, could be as much as 200 if you gave them a much larger dose. But it would always be never above 200 nanograms per milliliter. So when we see a level of 740, that tells me that you can only get to that level if you've taken multiple doses of cocaine. So you would have to take, that's what we call multiple uses or binging of cocaine, where you've taken multiple doses of it to get to that level.
And can you confidently say, based on your training and experience and expertise, that that potential binging of cocaine would have occurred within the last, say, 12 to 15 hours?
Yes, I think that would be fair. Okay, to say that we don't know the exact time, but it's certainly a window of use would be somewhere in that ballpark.
Okay. My approach again, Your Honor?
Yes.
Showing you what's been marked as Exhibit 34. You recognize that document?
Yes, sir. This is the runs from the liquid chromatograph mass spectrometer that the laboratory did, where they analyzed, did a quantification of benzoylecgonine, and then it also shows the cocaine and cocaethylene as being present, but they did not quantitate it.
Okay. Now, why would a lab not quantitate something that's present?
They have, every laboratory establishes what they call a level of quantification, or some laboratories could recall that a report limit. So that is the lowest limit that you can actually quantitate and say how much is there of it. And usually a laboratory will use that as their report limit. I did not have what's called the standard operating procedure from this laboratory to know exactly what their limit of reporting is for the cocaine. But whatever it was, they didn't report it because it was below that standard for their laboratory.
Right, so can you say that even though it's below the standard for reporting, that there's no doubt that those substances were present in the blood?
Yes, the chromatograms clearly show that those substances were present.
Right. May I publish Exhibit 34 here?
Yes.
To move into evidence.
No objection. Exhibit 34 is received and marked.
See that, Dr. Valentine?
Yes, sir, I can see it on the screen over here.
And accused described very briefly what you see there.
The red lettering and so forth is mine. Actually, I put that on there just to illustrate this. And you can see where the description is. So I've got a little rectangular box. What the laboratory does, they assign what's called an accessioning number to a sample when it comes in. It doesn't go through, when it went through the laboratory, it didn't have Mr. Acevedo's name on it. It had a session number was assigned to him. And so this particular session number is his sample. And up at the very top, it tells you that when they actually ran the sample on this. And then we see, yes, I'm sorry.
And that date, when they ran the sample, was May 12th of 2020, is that right?
That's correct, yes.
Okay, I'm sorry, continue.
And then right below that is the, you see it's called benzoyl-ecgonine. And you see that peak, we call that a chromatographic peak. It goes up like that. It's shaded in. And when it's shaded in by the instrument, it means that the instrument's quantitated the value that's underneath it. If it's not shaded in, it means it has not quantitated it. Now look right below that, the line below that, it shows benzoyl-ecgonine. It calls it D, I can't quite say it, D3, I believe, benzoyl-ecgonine. What that is, that's an internal standard that the laboratory puts in. They put in a benzoyl-ecgonine that's deuterated. It's got heavy hydrogens on it, and it could never appear in the body. So it's used as an internal standard. They put that in there. So if the benzoyl-ecgonine peak comes out at the same place that deuterated sample came out, that gives you confidence that it was benzoyl-ecgonine.
So, all right, thank you, doctor. And forgive me if you've already answered this question, but the cocaethylene we see there, again, briefly, what is cocaethylene?
Cocaethylene is the metabolite that's formed by the concurrent use of cocaine and alcohol.
Does cocaethylene itself have a pharmacological effect on the body?
Yes, it does. In fact, it has a greater euphoric effect than does cocaine itself. And that's the reason people will abuse cocaine by drinking alcohol along with it, because they get a greater euphoric high.
Okay, and you discussed before the euphoric effect people get when they take cocaine, correct?
Yes, sir.
And that is a fairly short-lived effect on the body, is that right?
It is.
Is there an effect on the body after that you can attribute to cocaine use that occurs after the euphoria is gone?
Yes, we didn't talk about that. What happens is that when you, in the body, it's just like the old principle from physics: for every reaction, there's an equal and opposite reaction. Same thing is true of our bodies. If we stimulate our bodies, then there's going to be a price to pay later. We're going to have a period of depression, okay? And so what happens if you use the cocaine to get the euphoria, you get this really good feeling of it after you use the cocaine. But as that starts to wear off, you get what's called dysphoria. You get just the opposite effect. So now you'll get, instead of a happy, good feeling, you'll get a feeling that's not so good. And that's what we call dysphoria. And unfortunately, that lasts a little bit longer than did the euphoric stage. So for a period of about 2 to 4 hours after using cocaine, a person will be in this dysphoric stage. And then the other thing that we talked about earlier was the cardiovascular effects of cocaine. Those tend to last for about 3 to 4 hours. So the person can be very uncomfortable with their heart pounding and their blood pressure being up for 3 to 4 hours before that finally starts to come back down to a baseline kind of where they were before it started.
And that blood pressure rising that you discussed, that is attributable to the vasoconstriction or constriction of the vessel effect that cocaine brings. Is that true?
Both that as well as the increase in heart rate.
Okay. And regarding this dysphoric effect on the downside of using cocaine, can you say, based on your experience, education, and training, whether that often leads people to seek more cocaine?
Yes, what happens is that a person that uses cocaine regularly, we call it a powerful reinforcing drug. That is, if they get into an environment where they're with people that have used cocaine before, they have a high urge to use the cocaine. If they go into a room where they've used cocaine before, they'll have an urge to use cocaine. That's what we call a reinforcing act of it. The other is that because of this euphoric effect that they get, they want to repeat that again, and sometimes they want to repeat it more frequently, and that's the reason we get into the binging use of the cocaine. So it's kind of an insidious thing in that when you start using it, it has a very powerful reinforcing effect.
And Dr. Valentine, the opinions you provided this morning regarding Mr. Acevedo's estimated blood alcohol level based on the urine screen, the results of your review of the runs and the toxicology screens regarding cocaine, and the timing of the use of that cocaine, are all those opinions offered today to a reasonable degree of medical certainty?
Yes, sir, absolutely.
I have no further questions for Dr. Valentine.
Thank you. Mr. Tiffin?
Doctor, just explain, what's a metabolite?
Yes, when one uses cocaine, you get really two major metabolites. The most major one is the benzoyl-ecgonine that we've been talking about. And the second one is the ecgonine methyl ester.
And so let's assume I were to ingest cocaine through my nose.
Yes,
It goes right into my blood, correct?
it does. It gets in almost immediately.
And then it gets cleaned, for lack of a better word, through my liver, correct?
Correct. No, it bypasses the liver on the first pass through the body because you've taken it in through the nose. So you get cocaine going directly to the brain, basically on the first pass of the blood. Once that blood starts to recirculate, then it's going to go through the liver, and then it'll be metabolized to the benzoyl-ecgonine and the ecgonine methyl ester.
And what a metabolite is basically when you're breaking down the original substance. Is that?
It is basically it's the body's mechanism to try to get rid of the drug.
And those metabolites then are secreted through the urine, possibly through your sweat. Is that correct?
Yes, sir, that's correct.
Correct me if I'm wrong, but what we know is that urine was taken from Mr. Acevedo at the hospital.
Correct.
About what time?
It was about 1,400 hours.
Okay, so that would be
I'm sorry. It was 11:32.
okay. Serum blood was also taken, correct?
Yes, sir, it was.
The urine showed ethanol, alcohol, correct?
It did.
The urine showed benzo, the metabolite of
Correct.
cocaine,
Correct. Yes, sir.
The blood that was taken, which was tested by the crime lab, and that blood was taken when?
That was at 14. Let's make sure we get the times right on. I believe that was 14:10 hours.
So roughly,
I'm sorry, 16:10 hours.
so roughly 4:10 in the afternoon, correct?
Correct.
The blood was screened. It also showed alcohol or ethanol, correct?
It did. Yes, sir.
It also showed benzo.
It did.
From the instrument that tested the blood, you also saw cocaine, not the metabolite, but it wasn't measured because it was below, or you assume it was below the level of the lab, correct?
Correct.
If cocaine, that actual item, or that actual substance, disappears from the blood within 1 hour, and we assume that no cocaine was ingested in Mr. Acevedo after he was admitted to the hospital, which would have been roughly 6 hours before, why would there still be cocaine in the blood?
Yes, sir. That's a very good question. And the reason probably is because of his clinical condition. We know that he was on a ventilator. We know that he was clinically very tenuous at that point in time. And so the body just kind of shuts down at that point in time. And I think that's probably the reason it was there. It could be some coming back out of tissues that were in his body and so forth.
Okay. Fair to say that because of the condition he was in, the ventilator, the body stopped filtering, stopped doing what your body does. Is that correct?
That's correct.
You had talked about retrograde extrapolation. That's basically a process where if you know, for example, an alcohol level at a certain time, you assume that the body excretes or metabolizes alcohol. I think it's 0.015. The clearance rate is 0.015 per hour, correct?
Grams per deciliter per hour. That's correct.
So this idea of backward extrapolation, you sort of take this level, you add 0.015 for each hour to try to go back.
That's correct.
But you don't think that's a dangerous or, not dangerous, but just not something that should be done because there's too many assumptions. Is that correct?
Yes, sir. In this particular case, again, because of his clinical condition we were talking about, we don't know how that alcohol was being cleared from his body, okay?
With respect to cocaine, is there a corresponding average rate of clearance? You know, I'm comparing like alcohol is 0.015. Is there a corresponding one for cocaine?
Yes, sir. What we usually use is the half-life of the drug. In cocaine, the half-life is considered to be 30 minutes to an hour.
It is fair to say that Mr. Acevedo, prior to being admitted at the hospital, and tell me if you disagree with this word, had recently used alcohol.
Yes, sir.
Is there, the word recent can be a subjective term.
Yeah, yes.
Is there any way to say how, you know, to give a number, a time?
No, we can't really. I mean, that's what I was saying. We had no information really when he started drinking, when he stopped drinking, what he was drinking. We had no information on that.
It is fair and accurate to also say, and again, correct me if I'm wrong, that prior to his admission to the hospital, Mr. Acevedo had recently ingested cocaine.
Yes, sir.
Also, for the reason you just said, is there any way to say how recent vis-a-vis when he was admitted?
No, we can't say how recent. There's no way to do that.
Okay. But we know he had some cocaine. We know he had the metabolite of cocaine. We know he had the metabolite of THC in his system. We know he had the metabolite of nicotine. We know he had alcohol in his system, correct?
Sir, that's correct.
Did you observe anything else of relevance or substance in his body?
No, sir, that's all the information I had to go on.
Okay. I have no other questions.
Thank you. Mr. Powell?
Just briefly, and so while you can't pinpoint the time of a last drink or a last ingestion of cocaine, again, you can say, based on what you do know and have, that it would have been, and we use the term recent. I agree with Mr. Tiffin that is sort of a subjective and nebulous phrase, but on direct you talked about being comfortable saying that cocaine use had probably occurred with at least in the last 12 to 15 hours. You're still comfortable with that?
Yes,
is that right?
I'm comfortable with that, okay.
All right. And even though Mr. Acevedo's body had sort of shut down, as you said, by virtue of what happened, if that indeed is what, let's say that stopped the metabolization or the processing of alcohol in his body, if a urine sample of 270 at 11:30 in the morning, that would still indicate consumption of alcohol in the hours at least preceding his hospitalization.
Yes, that's absolutely right. I mean, the alcohol would be clearing into the urine within 4 to 5 hours for certain would clear into the urine. So we had that urine level. It means that the alcohol had been used fairly recently.
Okay. That's all I have for Dr. Valentine, Your Honor.
Thank you. Mr. Tiffin?
No other questions for the doctor?
Thank you. Thank you, Doctor.
Thank you.
I would move exhibits 33 and 35. I think I already moved 34.
Okay. Any objection?
No.
Exhibits 33 and 35 are received and marked.
Thank you. Defense calls Dr. James Pearl.
Sorry, you can raise your right
Oh,
hand.
sure.
Do you solemnly swear that the testimony given in this matter will be the truth, the whole truth, and nothing but the truth, so help you God, or under the pain or penalty of perjury?
Yes, I do.
Thank you. Speak clearly into the microphone, state your name and spell it for the record.
James Lawrence Pearl, MD.
Good morning, Dr. Pearl.
Doctor, can you spell your last name?
Oh, sorry, Pearle.
Thanks, sir. Okay.
Good morning, Dr. Pearl.
Morning.
What is your current position? What do you do for a living?
Well, I'm a pulmonary physician. Over the years, and even now, I wear a bunch of hats. I have a pulmonary private practice where I see mostly pulmonary consulting patients 3 or 4 half days a week. I do some legal work as I'm doing now. I'm doing some part-time work as a pulmonary attending, teaching the fellows at University of California, Irvine in Orange County, and still kind of finishing up the remnants of about 20 years that I spent running my own clinical research office, doing clinical trials for pharmaceutical companies. It's sort of ebbing down, but there's still a little residual work from that.
And describe briefly for us your educational background.
Well, I was an undergrad a little south of here at the University of Chicago. I went to medical school at New York Medical College in New York City. Now it's in Valhalla, New York. I did internship at Kaiser Hospital in Oakland, California. My medical residency at George Washington University in Washington, D.C. And I guess that's where, that's kind of where education ends.
And at some point in your practice, did you begin to specialize in pulmonary issues?
Yeah, it's worth just a little explanation of what the pulmonary specialty is. As people go through their medical training, the further along you go, you specialize more and more. I did an internal medicine internship and internal medicine residency. Internal medicine is kind of the study of the internal parts of the human body and involves brain, lungs, heart, kidneys, liver, spleen, things like that. That's the general field of internal medicine. Then after finishing an internal medicine residency, then I went on to a pulmonary fellowship for a few years. Pulmonary disease is the study of the lungs in particular, kind of in general diseases like asthma, bronchitis, pneumonia, tuberculosis, but particularly kind of pulmonologists of, I guess, kind of my age and my era, we were sort of the original hospital doctors. We started doing hospital consults, and I'm speaking of pulmonologists in general, taking care of hospital patients, and it turned out, kind of the nature of the fact that the lungs in the body are kind of the center of the universe, that pulmonologists became the doctors that took care of all hospital patients. So we were hospitalists before there were hospitalists. We took care of the intensive care patients. So we were the intensivists before there were intensivists. And now pulmonologists are sleep doctors as well. So kind of the nature of being a pulmonary doctor and that experience means you really work with the entire body, because what we do in the lungs kind of impacts everything.
Okay, and have you published articles in peer-reviewed journals?
Yeah, I think I've got about 8 or 10 peer-reviewed articles going back to fellowship on control of ventilation. When I was on the faculty at UCLA and had a chance to evaluate numerous shipyard workers who had been exposed to asbestos, I published a couple of papers about my findings, and that was sort of my introduction to doing some med-legal work. And then as a result of my pharmaceutical trials experience later on, we generated a few articles about the development of some of the newer drugs that we had the opportunity to be part of the trials for.
Are you board certified?
Yes, in internal medicine and pulmonary disease.
May I approach, Your Honor?
Yes.
Showing you what's been marked as Exhibit 36. Do you recognize that document, Dr. Pearl?
Yes, it's my CV. I'm not quite sure how current this is, but it's pretty representative.
Okay, in the last, certainly current as in the last year or two?
Yeah, I think within maybe 2 years. I'm just not sure this is my newest CV. I'm not sure you ever got that.
That covers the material your background experience you've just described, correct?
Oh, yes, sure.
Okay. And you were asked to consult on this case to review some historical medical records regarding a person named Joel Acevedo. Is that correct?
Yes.
All right. And can you tell us what you reviewed?
Well, there were copious medical records on Mr. Acevedo. I think I recall from 2016 through about 2019. I think there were, 1,000 or 1,200 pages of that were primarily emergency room visits and hospital admissions. I saw autopsy material. I have seen a video of the incident that's in question, and I think some other relevant documentation along those lines.
Let's talk about some basics. Can you just briefly explain to us or provide a basic description of the body mechanics of breathing or the respiratory system, how it functions?
Okay. The best way to think about the lungs is they're really a balloon or two balloons, and they work like balloons. When a person breathes, what they do is they contract their diaphragm, which is the muscle at the bottom of their lungs. So instead of being domed, it flattens out, and that expands let's call it the contents of the chest. And also when people breathe, people kind of describe this kind of a bucket handle mechanism, where when you breathe in, your chest and ribs move up and out, as I'm kind of demonstrating here. So those are the ways that the chest expands. Now the lungs, these two balloons, sit inside the chest cavity, and there's a space between the inside of the chest wall and the outside of the lung. That space is called the pleural space, and the pleural space is negative pressure. And by negative pressure, that's what keeps the lungs expanded. If there wasn't this negative pressure, the lungs would collapse just like a balloon that sits on a table. So when people breathe in, by lowering their diaphragm and expanding their chest wall, they create more negative pressure in the pleura and in the chest, and the lungs expand to follow that.
That's, and when that happens, the lungs expand. That's what sort of pulls air in via the mouth, down the trachea, into the airways. And then when breathing is ended, it sort of the chest kind of passively contracts and we blow out. And then when that air gets into the lungs, the air or oxygen that's in these little air spaces in the lungs called alveoli, oxygen gets transferred from the alveoli across a very thin tissue or membrane into the capillaries that are the blood vessels in the lung. So oxygen goes into those capillaries and gets circulated throughout the body. And conversely, carbon dioxide, which is, let's call it the waste product of ventilation, moves from the capillaries through that same membrane back into lungs to be blown out. So the lungs mechanically breathe air in and out, and then at this more basic level, oxygen goes from the lungs into the bloodstream, circulated to the tissue, and oxygen is, you know, the energy, it's the fuel of the body.
So oxygen delivers, or the lungs deliver oxygen to the blood, which the blood is then pumped by the heart into other parts of the body.
Yes, that's correct.
Okay. And you mentioned before different respiratory diseases. You mentioned asthma in particular. What is asthma?
Well, asthma is kind of a spectrum of disease. What people used to define asthma as a disease that defined by reversible obstruction in the airways. In other words, think of your airways in the lung, bronchi or bronchioles, as tubes surrounded by muscles, and that they can constrict, those muscles can constrict and relax. And in asthma patients, that constriction of those muscles surrounding the airways is rather profound, probably much more extreme than happens with you or me. So lung function can improve by, or air, let's call it this way, airflows can improve or get worse, you know, by 15, 25% or worse in patients with asthma. Now, over the last 10 or 15 years, the pulmonary world has kind of recognized that it's not really the muscles and that reversible obstruction that's really a feature of asthma. What really is the feature of asthma is inflammation in your airways. And inflammation you can think of as spraining your ankle and it's red hot, it's inflamed. You get a burn on your skin, it's inflamed. The airways get inflamed too, and that's really the core disease of asthma is this inflammation. And then obstruction, as I kind of talked about, is kind of secondary to that. So we have to think of asthma as this two-part disease of airways inflammation and obstruction. It can vary from really mild disease where people just have a little bit of obstruction, and when that obstruction produces a whistling sound, we call it wheezing. That can be relieved, you know, in a couple of minutes with a rescue inhaler to open up the airways. And at the opposite end of the spectrum is people who have terrible inflammation, terrible obstruction, are never controlled, require, you know, really extensive medicines, including exotic stuff like injectable biologics, and need that to function at all. So the extreme cases of asthma can wind up in the hospital, and people still die of asthma if their obstruction is too severe and remedies don't work.
You said obstruction is secondary, or can be secondary to inflammation, is that right?
Yeah, think of inflammation as the core underlying process, and obstruction is secondary to the inflammation. Now, the obstruction has a couple of different components, but inflammation is really the core of it.
Yes.
Show this marked as Exhibit 38. You recognize this?
Yes, I think actually I sent that to you as kind of a representative graphic.
It's a graphic of basic, I'll put up for the jury we can talk about it here.
It's up there. It's not.
Sort of a basic illustration of airways, and describe what you see there for the jury.
Well, on the left is sort of a graphic picture of what the lungs look like, and I think when you see that picture of the lungs sitting in a picture of the chest wall, you can understand why describing the lungs as a couple of balloons is really a good example. Those lungs expand or contract depending on movement of the chest wall and the diaphragm. In the middle is a typical normal airway. Now, the airways carry air from your mouth down through your upper airways, down into the trachea, which is the big tube that you can kind of see in the middle on the picture on the left. And then these airways divide off and keep having serial divisions until it goes out to a really microscopic level. That's how oxygen is delivered to these tissues. The middle picture is a normal airway. And I mean, to make a long story short, the normal airway is just kind of an open pipe. There are some muscles that surround that. There are the tissues that make up the lining of the airways, and you can, that's sort of the kind of pinkish tissue.
Right here?
Yeah, I mean that's the kind of the lining of the airways, and then there's kind of a wide open airway, and you can see that it's pretty easy mechanically for air to be able to go in and out through those tubes without resistance. Now, on the lower right, a kind of a dramatic picture, but it makes the point that that's obviously not a normal airway. When I talk about inflammation, you can see that tissue that's lining that is lining the airways is red, it's thick, it's edematous, it's swollen, and when that happens, that in itself can make the airways constricted and narrowed on a kind of a permanent basis, because that doesn't really change really quickly. On the outside of that tissue surrounding the airways is a ring of muscle. And that muscle can constrict the airways by contracting the airways and making them smaller. And in people with asthma, those smooth muscles can be enlarged and thickened and really sensitive to be able to go into spasm, at the drop of a hat or kind of an irritation.
When those muscles go into spasm, what happens?
Well, that's when people get acute obstruction in their airways because it narrows the airways. Think of instead of breathing through that open tube, it's like breathing through a straw, and those muscles can constrict really quickly. So that's why bad asthmatics are really sensitive to get into respiratory distress at kind of the drop of a hat. Now, the last thing to just show on there for just a second, just to kind of finish it, if you don't mind.
No problem, I apologize.
Is you see that sort of, I don't know, I guess it's kind of a greenish material that's in the airways. That's sort of a schema of mucus. Any of you that have had bronchitis cough up a lot of phlegm and mucus and junk. And that's produced as a result of inflammation by cells that line those airways. People with asthma and bronchitis have extra production of this mucus, and it can clog up the airways. Again, I don't think I have to kind of spell that out, because I think we've all experienced to some degree. But that's really the third factor of why people with asthma have airways obstruction. We talked about the muscles on the outside. We talked about the edema and swelling of the tissues lining the airways. And then the third thing is that the airways get clogged with a bunch of mucus.
Okay, move Exhibit 38 into evidence, Your Honor.
Any objection? No. Exhibit 38 is received and marked.
Thank you. So, Dr. Pearl, based on your review of Mr. Acevedo's records as you've described, what did you learn about Mr. Acevedo's respiratory or pulmonary condition?
Well, a few things. I mean, the first is his general course for the couple of years of which I had available. Again, I think the end of 2016 through 2019 was kind of a continuum of multiple trips to the emergency room, of being hospitalized in respiratory distress, with these episodes occurring either rather quickly or a result of infection. So the clinical picture is of a gentleman with chronically bad asthma, difficult to manage, not really well managed, particularly, who seem to be at risk most of the time to get sick, to have infection, to have his asthma flare up and wind up in the hospital.
And in those records of hospitalizations, were there some that were specific appearances or hospitalizations related to respiratory issues?
Yeah, I didn't really count the number of admissions, but almost every admission for him was some version of a respiratory illness, whether it was asthma or bronchitis or pneumonia, all of which kind of put together to make him short of breath, cough up phlegm, wheeze, and be in respiratory distress. So it's kind of a continuum over a couple of years.
And what is an FEV1 test?
Well, when pulmonologists like to measure lung function, because it tells us how well the lungs are working, and it kind of translates into working numbers. Now, lung function, meaning how open the airways are or how much air flows, isn't the only thing to talk about in asthma, because you can't really measure, at least in real life, the inflammation, but you can measure the obstruction. So what you do is you have an individual take a deep breath in, put his mouth on a measuring device, and blow out as hard and as fast as he can. And that's a maneuver called a spirometry. And you can measure different components of the rate at which the individual blows air out. A good shorthand value that kind of tells us how severe airflow obstruction is in asthma is the FEV1, which stands for forced expiratory volume 1, meaning how much air can that person blow out in the first second. And then you compare it to a predicted value for that person's age, height, and ethnicity. So those predicted values aren't absolute. There's a range of normal for people depending on their age, height, and ethnicity, and then you can compare what the individual actually does in terms of how much air he can blow out to a predicted normal value. So so again, the shorthand for obstruction in asthma is what does someone blow out in the first second compared to predicted value? Now, most of us in this courtroom who are pretty healthy with normal lungs blow out about 75% of all your air in that first second. And if people who have obstructed or narrowed airways can't blow out that fast because their airways are obstructed, and I think we all saw the picture of the airways, so you can sort of understand the mechanics of that. So you measure that value, how much can they blow out, say 2 liters of air, for example. You compare that to what a normal person should be doing. Let's say a normal person should be doing 4 liters. Then you can say that the FEV1 as a percentage of predicted value is 50%. In other words, he breathes out 50% of the air that a normal person would be able to do.
So in your review of Mr. Acevedo's medical records, and to be clear, the example you just gave of 2 liters versus 4 liters was just a hypothetical example.
Yeah, I just wanted people to kind of understand how that calculation has arrived.
Right, but you were able to observe a spirometry test, FEV1 results in Mr. Acevedo's records, is that true?
Yes.
All right, and describe generally your impression of those results.
Well, fortunately, when Mr. Acevedo had a complete, more sophisticated set of breathing tests done back in 2016, but during many of his admissions, the respiratory therapists did spirometry maneuvers obtaining FEV1 values at different points in his treatment. And it gives us an idea, number one, of how his airflows were at a particular point in time, but sort of gives us an idea of trending as to what he does over years.
May I approach again, Your Honor?
Yes.
To show you what's marked as Exhibit 37, Dr. Pearl, do you recognize that document?
Yes, I do. I mean, this isn't the actual one I prepared, but I recognize the numbers. This is what I had calculated myself.
Okay, and so what do you see on the page?
Well, what we've got is we've got FEV1 as a percent of predicted at about 8 or 9 time points during Mr. Acevedo's medical chronology. The first set that he had in 2016, his FEV1 as a percent of predicted was 92% of predicted, which is pretty normal. But then you start seeing what happens when he shows up sick and in hospitalizations. And as you can see on 8/12/17, his FEV1 percent of predicted was 24%. That means during that acute episode, when he showed up in the hospital, his airflows were one quarter of normal. Then to show you how labile he is, just a couple of days later on 8/16, his FEV1 percent is up to 104%. That means he improved, I guess what you could say 400%, just in a couple of days from his low ebb.
And you say labile, what do you mean?
Labile means that his airflows go up and down, that his that his airways were sometimes really obstructed and sometimes not, but was going through a lot of extremes. That's pretty scary if your lung function is normal and then in just one episode, all of a sudden you're down to a quarter of normal lung function.
And what is a quarter, 24%? Is that a dangerous level?
Yeah, that's, I won't say that it's absolutely life-threatening, but that's about as bad as asthmatics get. And what happens if you reach a point where lung function is worse than that, then there's a point at which just lung function and airflows just won't keep you alive, and people die of something. At 24%, obviously he hadn't quite reached that point, but that's really bad for an asthmatic. And then just 6 days later, with aggressive hospital treatment, he improves to 104%. Then in May of 2018, he's back down to 35% on another visit to the emergency room. And then in 2019, he does it again, where they did serial breathing tests, where he came in at 29%. And then you can see just over the next, 24 hours or so, you see that he improved from 29 to 41 to 52 to 54 to 67 to 70%. That's how, and that's in 24 hours that his lung function, tripled. So to 70%, not so bad. 29% or 24%, pretty awful.
Thank you, Doctor. Did you see anything in Mr. Acevedo's records regarding an immunoglobulin deficiency?
Yes.
And briefly, what is that?
Well, immunoglobulin is a protein in the body, or there are several proteins, and you kind of think of them as either identical or kind of interchangeable with antibodies. In other words, antibodies are the substance that the body uses to fight off infections. And typically, immunoglobulin G, I don't want to go too far into the weeds, but immunoglobulin G is really the immunoglobulin that is particularly important for helping individuals to fight off infections. Most of us are normal and have normal immunoglobulin Gs, meaning our immune system is working reasonably properly. With Mr. Acevedo, starting at the beginning of the records, 2017, I think, he was recognized to have immunoglobulin G deficiency. So think of that as meaning he didn't have the immunity that you and I and most of us have, because he didn't have these antibodies to fight off infection.
Is there an association between immunoglobulin deficiency and asthma at all?
There's an association that's not exactly direct, but it's there. IgG deficiency is generally pretty rare, but at least I've read that in a couple of different studies that in asthma patients, about 5% of asthma patients have immunoglobulin deficiency. So what happens with immunoglobulin deficiency is you don't fight off infections very well. And the typical infections that people with IgG deficiency get are respiratory infections. Think nasal congestion, infections in the sinuses, infectious bronchitis in the airways, and pneumonia. People with asthma, before even talking about their immune system, are already predisposed to get infections in their lungs. Because of all that inflammation and obstruction, they don't clear out their lungs very well. They don't sweep the bacteria and garbage that we inhale all the time. They don't sweep that out very well. So asthmatics are prone to get infections anyway. And when infections happen, that makes all the inflammation worse and makes the obstruction worse. Now, asthmatics who have immunoglobulin deficiency are just worse on all these fronts. They get more infections. They don't fight them off as well. They persist longer. And consequently, asthmatics with immunoglobulin deficiency are in this constant spiral where, because they're getting infected, the airways get more inflamed and get more obstructed. And because they're more inflamed and more obstructed, they're less able to handle infections, so they're prone to the next one. And after a while, they build up a bunch of chronic, semi-permanent disease in their airways, a little bit like that slide that we looked at about 20 minutes ago, the one that showed the pretty obstructed airways. So everything that happens with asthmatics is worse when they have immunoglobulin deficiency, even though there's not like a direct causative link between the two.
In your review of the medical records for Mr. Acevedo, could you tell whether Mr. Acevedo was consistently getting his treatments for the IgG deficiency?
Well, it's not crystal clear in the records, but there seems to be a sense that he was getting in his let me backtrack a little bit. You treat immunoglobulin deficiency with injections of immunoglobulin, which people get maybe once a month, and it helps to replace the missing immunoglobulin and helps to fight off infections. So people who have immunoglobulin deficiency and it's recognized get put in a program where they get injections or infusions of immunoglobulin every month or so, which kind of tries to normalize their immune system. It looks like he was on some schedule of getting immunoglobulin on a regular basis, but there was a note or two, I think at the beginning of 2019, my recollection is around February of 2019, whereas doctors mentioned that he wasn't getting his immunoglobulin shots, maybe because of insurance issues, but he didn't quite parse out the reasons. But there were a couple of references to immunoglobulin shots stopping around February of 2019.
All right. Moving on to another topic, does smoking cigarettes or anything, how does that affect an asthmatic?
Well, I mean, smoking is a terrible cause of inflammation and irritation to the lungs, and pretty much everything that happens with an asthmatic is worsened when people are smoking because you're continually adding an additional insult to those already sensitized airways. Now, smoking can cause lung disease by itself without needing a milieu of asthma to work on. But when people already have asthma, smoking is a bad aggravating factor for those individuals.
Now, after you reviewed the records in this case, you drafted a short report, correct?
Yes, I did.
That was disseminated to the state. And in there, you commented that Mr. Acevedo's respiratory reserve was dramatically less than an otherwise normal person. What does that mean, his respiratory reserve?
Well, again, as we've kind of talked about it earlier, the lungs have a job. The job is to get oxygen to the bloodstream and then to the tissues, maybe most importantly to the brain and to the heart. And if you can't get air in and out of the lungs for mechanical reasons because of obstructed or narrowed airways, then it doesn't make any difference whether you give people oxygen or not. They can't get any oxygen to their tissues. Now, lots of different things can compromise your breathing, but most of us have a lot of extra reserve in our lungs. I mean, people can live on one lung, so you know that there's kind of redundancy or extra reserve in their lungs. But if you take that extra reserve away because of underlying disease, then there's no margin for error. So if something else happens on top of that, individuals can't make up for that by breathing harder or breathing faster. They're already doing the best they can. And you reach a point where that additional compromise, superimposed on this existing disease we talked about can be the reason people get hospitalized, I mean, or could be life or death.
And something, and correct me if I'm wrong, I'll ask it this way. Can strenuous exercise or strenuous physical exertion bring on difficulties in an asthmatic patient?
Yeah, yeah. I mean, exercise or stress is either or both are kind of commonly recognized as aggravating factors for asthmatics. Not really that they actually would cause asthma, but those are the kinds of things that make someone with sensitive and very reactive airways at risk for having the muscles surrounding the airways constrict and develop a bad obstruction and put them in distress.
Now, from your records review, you know that Mr. Acevedo was a 25-year-old man, correct? At the time of his death.
Yes.
How does his respiratory system look for a 25-year-old?
Well, I guess it's probably about as bad as you get for a young guy at age 26, with terrible lung function, chronic inflammation, and aggravating, and on top of that kind of intrinsic asthma, add a bunch of aggravating factors. The immunoglobulin deficiency, so he was getting more infections. Smoking, so his lungs were just continually being bombarded by chemicals and irritants and toxins and cigarette smoke. And we didn't really mention it, but he was also somewhat overweight, which is just another mechanical limitation of breathing that you can just put in kind of on top of these other factors.
It's fair to say his body simply did not move air as well as a healthy person.
Well, I guess what you could say is there were times when he could, but I mean, back in 16 and 2017, he at least on paper was moving a normal amount of air, but around those couple episodes of normalcy, he was on a roller coaster of lung function going up and down. So he might have had some brief times of normal lung function, but that's the nature of bad asthma.
I want to ask you about something you said you reviewed in this case. You said you watched camera footage of Mr. Acevedo on the ground and Mr. Mattioli sort of on his back with Mr. Acevedo in a prone position. You remember that?
Yes.
Okay. That position in someone, prone position, laying on their chest or stomach on the ground with someone on their back, how does that impact breathing?
Well, I mean, let me answer how I think it could potentially affect it. I don't want to claim to be an expert in that reconstructing that particular scene, but the way people breathe, as we talked about, is they have to be able to have their muscles in their chest pull the ribs up and out and expand the chest, as you've seen anybody take a deep breath. If you put someone on their stomach, I mean, even just being on your stomach with nothing else on it is a little bit constricting to your breathing, but doesn't affect most of us. I think it would affect Mr. Acevedo more. And in theory, if you applied additional pressure to his chest, preventing him from expanding his chest, then that would compromise his breathing. Again, I'm giving him a caveat that I'm not trying to reconstruct this circumstance at all. I'm trying to speak kind of in general.
In the report we described before, you noted that a physical event, your words, a physical event like the kind of respiratory restriction alleged in this case, and by that you mean Mr. Acevedo being on the ground with someone on his back, right?
Yes.
Okay. Could be benign in a healthy individual, meaning benign meaning not harmful?
Yes, just kind of I mentioned, I think.
Okay. that could, while be benign in a healthy individual, could prove to be catastrophic or fatal in an individual with multiple medical problems outlined in Mr. Acevedo's case.
Potentially, yes.
And do you hold that opinion to a reasonable degree of medical certainty?
Yeah, I mean, I hold that opinion to a reasonable degree of medical certainty in general, with the caveat that I'm not testifying as an expert on these specific circumstances. I'm only kind of answering that in general.
Right. And another way to say it is someone with healthy lung function and respiratory system put in the same position might not succumb the way Mr. Acevedo did because of Mr. Acevedo's respiratory issues.
Yeah, I don't know whether you want to call that hypothetical, but in general, I would sort of agree with your proposition.
Okay. Nothing further for Dr. Pearl.
Mr. Tiffin?
Doctor, the conditions that Mr. Acevedo had, I mean, he was living with those conditions for a number of years, correct?
Sure.
And you know that because you had medical records starting in 2016 through 2019, is that correct?
Yes.
Did you have the records when he was admitted to St. Luke's in April of 2020?
You mean that I'm not sure the dates, but that was his final admission?
Yes, that's the admission that ultimately he died.
Yes, I saw some of those records, not all.
From those records, was there any way to tell, and could you tell what his lung functions were upon admission?
No.
Okay. And so what we know, though, that his lung function over a period of the 3 years you described, your label, was a roller coaster. It'd be good sometimes, it would be bad, it would go up and down, correct?
Yeah, I think that's accurate.
And there's no way to tell what his lung function was on the day why we're here in court, correct?
Well, I guess let me answer that in two parts. I don't think there's a way of knowing actually what his lung function was or what his FEV1 was, but I think the evidence is clear that the background milieu was chronic inflammation. The inflammation was clearly present. What I can't tell you is whether at the time he was significantly obstructed.
With respect to the records from St. Luke's upon his admission that shortly before his death, did you see any evidence of infections?
Acutely, I don't think so. I'll caveat to say I didn't see all the records, but I didn't see obvious mention of that in the notes that I saw.
Okay. Asphyxia is what?
Asphyxia is depriving the brain of oxygen by some, I guess, of any of various mechanisms.
And if the brain is deprived of oxygen, the brain starts to die, correct?
Yes.
How long does that process take?
Well, I kind of didn't expect that we were going to go there, but it is worthy of some discussion. Generally speaking, the brain can stay intact in anoxia. Anoxia meaning low oxygen. We'll try to use that as being synonymous with asphyxia. Is that okay?
You use the words that are,
I'll
I'll ask you, you use the proper words.
Okay. I mean, asphyxia means ultimately anoxia or no oxygen or decreased oxygen to the brain. When under anoxic conditions, brain cells can survive pretty intact for about 4 minutes. Give or take a little bit, but I think conventional wisdom is at about 4 minutes. And after about 4 minutes of anoxia, brain cells start to die off, and it's been suggested as a rough guide that you lose about 10% of brain function per minute in anoxia after about that 4-minute interval.
If a person is suffering or is in actual respiratory distress, okay, from, for example, the conditions Mr. Acevedo had, would you hear the wheezing? Would you hear noise? Would you hear anything?
I mean, not necessarily. I mean, you have to move air to produce wheezing, just as a clarinet or an oboe produces sound when you blow air through it. If you're so obstructed that not enough air passes through to produce that musical sound, you might not hear wheezing. Also, in more overweight patients, breath sounds tend to be a little more distant and farther away. So you wouldn't necessarily hear wheezing whether someone's has normal airflows or bad airflows. You can't say for sure.
Did you listen to the 911 call?
I
That's
heard
not the video. That's just the,
yes, I did.
okay. Do you recall hearing like the noise of exertion or heavy breathing or anything that was significant?
Well, there was a period, I mean, a few short periods of some heavy breathing, but I must say, I couldn't draw any conclusions from it. I mean, I wouldn't, all I heard was heavy breathing. I wouldn't clearly describe it as wheezing or stridor, which is the sound you produce when people have upper airways obstruction. And I don't really know who was producing that sound. So I just have to say, I just don't know what to make out of that whatsoever. I just don't think I'm qualified to opine on that.
Okay. Colloquially, people use the phrase heart attack. Does that mean anything medically?
Well, yeah, I mean, a heart attack is generally would be defined as the heart, some heart cells dying as a result of low oxygen flow to the heart.
Is that synonymous with cardiac arrest?
Not really. You can have a heart attack without cardiac arrest, and you can have a cardiac arrest without a heart attack.
And what does cardiac arrest mean?
Well, cardiac arrest means the heart stops functioning. The heart is a pump, and it's kind of on a metronome, and it pumps a certain amount of blood through the body into the tissue on a regular basis. Think roughly 60 times a minute. If that heart stops contracting on that regular basis, and again, the heart contracts like a pump and ejects most of the blood in it if the heart's working properly. If the heart's not contracting, no blood flows, so no blood flows to the tissues, no blood flows, importantly, to the brain, and there are a couple of different mechanisms how that lack of heart function occurs.
What are some of those reasons?
Well, I think the primary reason is that we're most familiar with is ventricular fibrillation. The ventricle is the big pumping chamber of the heart. And in fibrillation, the heart loses all its synchronized contraction. In other words, if the heart's working normally, all the nerves to the heart muscles and the heart muscles are all contract in a nice synchrony. They all work together, so you get this nice pumping action. In ventricular fibrillation, the heart just quivers like, well, it's getting to be holiday season, like a bowl full of jelly. It just fibrillates around because there's no purposeful contraction happening. there's electrical activity, and if you look at an electrocardiogram, you'll see just a bunch of jerky lines going up and down, which is this disjointed heart rhythm that's going berserk, but it's not translating into contraction, so the heart doesn't pump. That's one version of cardiac arrest. The second is a little different, and you'll see it described often as PEA, pulseless electrical activity, which means that you can see on an electrocardiogram, you can see that the electrical activity looks okay. It's sort of regular, and it seems okay, but there's no pulse and there's no blood pressure, which means the heart function, even though the heart is getting the right electrical activity, the muscles just aren't contracting at all. So the heart is doing nothing, even though the EKG might do okay, and that's, you know, PEA, or pulseless electrical activity. You know, then the third version, I guess, is like complete cardiac arrest, no heartbeat, no electrical activity, nothing. I guess that's the third variation that you could talk about.
You had talked about the lungs, essentially, you analogize them to balloons, where when we breathe in, the balloons expand. When we breathe out, the balloons contract, correct?
Yes.
And if I were to be lying chest down on the ground, my natural weight might make it a little difficult, but if I were to add 200 pounds on my back, it would make it more difficult for me to breathe back in after I exhaled. Would that be correct?
Yeah, in general, sure.
So weight on a person's back, once your chest has contracted, when you have breathed out, a heavy weight on your back might make it more difficult to get air back into the lungs. Fair?
Yes.
Could that also cause the heart, which is a pump, to stop pumping? And by that, I mean the heavy weight on your back.
I think I would have trouble making that direct association, although maybe a cardiologist might have a different opinion. But I wouldn't think that in a pristine heart, all other things being equal, that pressure on the chest would likely make the heart stop. I think the heart could respond badly to compromised lungs in that situation, but I'm having trouble putting a nexus between just that pressure and cardiac arrest. I can't go further on that. That gets a little outside of my knowledge.
Okay. The phrase cardiopulmonary arrest, is that synonymous with or different than cardiac arrest?
Well, I mean, it's kind of splitting hairs, I guess. Ultimately, both the lungs and the heart have to work for people to stay alive and to function okay. You can have a cardiac arrest, but still have, at least for a while, enough residual brain function for the brain to send the messages down the lungs to breathe. So you could have a cardiac arrest and it's not respiratory, or you could say it's not respiratory yet. Maybe 10 minutes down the line, it might be respiratory. So you can have a cardiac arrest without respiratory arrest occurring at that time, because just as the heart has this basic instinct to want to keep breathing, the brain at its basic mechanism keeps trying to send messages to the lungs to keep breathing as well. So the messages that go to the lungs are really the most primitive and the most basic. And in brain injury or brain death, that part of the brain sending messages to the lungs to breathe, is kind of the last thing to go. So you can have a cardiac arrest if you do nothing to them and you don't fix that sooner or later, you're going to have a respiratory arrest to follow, but they might not be simultaneous.
Okay. I don't have any other questions.
Thank you. Mr. Powell?
Nothing further.
Okay, thank you. Thank you, Doctor.
Okay, thank you all.
Step down. Sir, if you have any exhibits, if you could.
Yes, I would move,
36 and 37, is that one?
no objection.
Exhibits 36 and 37 are received and marked. It's almost 11 o'clock. I think this might be a good moment for a break. We've been on the record for about 2 hours. So, ladies and gentlemen, we'll take about a 10-minute break. I'm going to ask you to leave your notebooks here. And again, remember, you can't talk about the case yet. So please hold on to those thoughts until deliberations. All rise for the jury, please. Please take your seats. Attorneys, anything else, Mr. Tiffin?
No.
Or Mr. Hart, Mr. Powell? Yeah. Okay. All right, folks, we're on break for about 10 minutes. Thank you. Recess. before we bring the jury in?
No.
No, Your Honor.
Okay. Right. Oh, there was one issue I wanted to raise. Well, actually, I'm going to raise it when the jury is here. And for the media, one of the jurors was concerned about the media being present, wants to be reassured that they are not being photographed, and they are not. And I'll just explain that when they're here. Okay, so can we bring the jury, please? Please take your seats. Members of the jury, the bailiff notified me that one of you had a concern about being possibly photographed during the trial. I want to assure you that will not happen. There is a media order in place. This trial is being covered by the media, but they are under strict instructions not to photograph you or identify you in any way. And so I just want to make sure you're aware that's not a concern that you need to have. Okay. We're going to proceed. The defense's next witness, Mr. Powell.
Defense calls Dr. Jeffrey Jensen.
Do you solemnly swear that the testimony you give in this matter will be the truth, the whole truth, and nothing but the truth, so help you God, or under the pain or penalty of perjury?
I do.
Thank you. You can have a seat there. Speak clearly into the microphone. State your name and spell it for the record.
I'm Jeffrey Jensen, Jeffrey Jentzen.
All right, thanks, Doctor. Mr. Powell.
Thank you, Judge. Good morning, Dr. Jensen.
Good morning.
What is your current profession?
I'm a pathologist employed at the University of Michigan.
And what is a pathologist?
A pathologist is a medical specialist who investigates disease and injury patterns.
And how long have you been practicing as a pathologist?
Since 1986.
And are you board certified in pathology?
I am board certified in anatomic, clinical, and forensic pathology.
Are you a member of any organizations related to forensic pathology?
Yes, I am a member of the American Academy of Forensic Sciences, the National Association of Medical Examiners, of which I was a past president, and the local, state, and other medical examiner offices, including the British Academy.
And I know you said you are currently at the University of Michigan, is that correct?
That's correct.
Was there a time in your career when you were the medical examiner for Milwaukee County?
Yes, I was the medical examiner in Milwaukee County from 1987 until 2008.
And as part of your job as a pathologist, you perform autopsies, is that correct?
Correct.
Over your career, do you know about how many autopsies you've conducted?
I estimate probably 13,000 autopsies or so, and I think I've probably supervised twice that many.
And I'm sorry, your stretch as the medical examiner in Milwaukee County was from when to when?
1987 until 2008.
And about how many autopsies on average you think you were doing a year?
I would personally perform roughly around 250 autopsies, And the office, over time would perform from 1,000 to 1,500 autopsies per year.
Okay, so you yourself, over that course of time in Milwaukee County as a medical examiner, conducted a couple thousand autopsies.
5 or 6, correct.
Okay. And as part of your job with the Milwaukee County District Attorney's Office, you would testify for the state, correct?
My job was with the Milwaukee County government, and as part of that, I would be subpoenaed by both the prosecutor and defense to testify in court.
Okay.
Predominantly, however, with the prosecutor's office.
Okay. And can you estimate how many times you testified for the Milwaukee County District Attorney's Office in which they relied on your opinions regarding cause and manner of death?
I would estimate 1 to 3 times a week.
For the entire course of your career at the Milwaukee County Medical Examiner's Office?
Generally, yes, that'd be an estimate.
Okay. You were asked to, I'll strike that. I've asked if you're board certified already, correct?
Correct.
All right. You were asked to review some materials regarding the death of a person named Joel Acevedo, correct?
Yes.
And what materials did you review?
I reviewed his medical records, the autopsy report, the medical examiner's report, police reports, the criminal complaint, videos, autopsy photographs, the toxicology report, and there may be something else.
Did you also review ante-mortem photographs taken of Mr. Acevedo at his admission to the hospital?
I did.
In regarding reports you reviewed, you referenced an autopsy report that was done by a Dr. Brian Peterson, correct?
Yes.
You were given, or no reports by a Dr. Tolomac were produced for you to review, right?
There was a 1-page report on microscopic analysis by Dr. Tolmack. I believe it was in September of this year.
And that was the only thing from Dr. Tolomac that you were able to review?
Correct.
And we'll talk about that addendum in a minute, but that related to microscopic review of organ sections from Mr. Acevedo, right?
That were available, yes.
Okay. So let's talk about some of what you saw. The autopsy report, let's talk about it this way. You've been involved in a lot of death investigations, obviously.
Yes.
Yes. All right, so would you agree that a medical examiner faced with a situation where you have a deceased person after a violent struggle needs to be a complete investigation of the circumstances of the death? That's one thing you have to do, correct?
Yes.
Would you agree that it is important that a complete autopsy would be done?
Yes.
And a complete autopsy would include a microscopic survey of the organs,
Yes.
especially the heart.
I would say that would be a major concern, yes.
Okay. And in this case, based on the materials you had to review, were you able to take or make any examination or review any examination of Mr. Acevedo's heart?
No, there were no microscopic slides taken, no description of the autopsy, and no associated report.
Were you able to determine why that was?
There was a diagnosis on the autopsy sheet that indicated that there was a postmortem, there was donation of the heart.
The heart had been removed for transplant?
Yeah,
Or for organ donation purposes?
for organ donation purposes, yes.
Okay. And based on your experience as a medical examiner, does that have to be approved by the medical examiner's office?
Yes.
And can you tell from the records you reviewed whether the Milwaukee County Medical Examiner's Office approved that removal of the heart for donation?
They did.
And in your time as a medical examiner, have you ever been asked whether an organ can be removed for donation?
Certainly on a number of occasions.
And did you always say yes?
No.
Why would you say no?
If I could expound slightly.
Please.
I'm very supportive for organ procurement and donation, and I've developed a number of programs to improve the practice of it, which has resulted in numerous donations. There are rare occasions where the outcome of other individuals depends upon examination of some of the organs. And so in rare cases, I would say in less than 1% of the cases, it's necessary to decline the removal or retention of the organ for examination. It may be the heart or it may be the brain, typically. And in those cases, we're now required to notify the family, but on rare occasions, I would decline the removal and retention of the heart or brain.
All right, in this case that you reviewed, you became aware that the circumstances of Mr. Acevedo's death involved him being in a struggle with Mr. Mattioli, correct?
Correct.
And when the first responders arrived, Mr. Acevedo was found to be unconscious and not breathing, right?
Correct.
All right. And based on the circumstances of the case, as you know them now, and as a medical examiner of your pedigree and experience, if they had come to you and asked you for permission to remove Mr. Acevedo's heart for donation, would you have approved it in this case?
No,
Why not?
because of the importance of the organ and the overall investigation of the case, and the knowledge that there was pre-existing medical complications that may have affected the health of the heart itself.
And if you had had the heart to look at or review, what would you have done, and what could that have told you about what happened?
I could have looked at the microscopic sections and also the structure of the heart, and especially its weight to determine if it had been damaged by, for example, lung function or other disease entities.
All right. There's been testimony in this case that it is not known what ultimately happened to Mr. Acevedo's heart after it was donated or removed. What do you think about that?
I find that very incomprehensible, that there would not be a knowledge that either the heart was successfully transplanted into another person, or that the heart valves were recovered, and then there would be a report somewhere from the institution that recovered the heart.
And based on what you were able to review in this case, you have no idea yourself what happened to that heart.
No, I do not.
All right. So let's talk a little bit about the materials you reviewed and what you have concluded based on those materials and your review. You understand, well, strike that. Based on your review of all the materials you described, do you have an opinion about whether Mr. Acevedo had his neck compressed by Mr. Mattioli in a manner that would compromise his breathing or blood flow?
I have an opinion.
What is that opinion?
It's my opinion based on reviewing of the video and the antemortem and postmortem photographs that there's no objective evidence that there was compression of the neck area.
And what would you expect to see as objective medical evidence if there had been compression of the neck area?
We would typically see hemorrhage deep into the muscles of the neck. There would be cyanosis, or a bluish discoloration of the face of the individual at the time that the paramedics arrived. There would be really prominent petechial hemorrhages of the eyes, which would be one of the findings that would be there.
Would you also expect to see petechiae in the oral cavity or throat?
Well, that would be an area both underneath the lips and deep into the lining of the airway.
And Dr. Peterson's initial autopsy report did not reveal petechiae in those places, correct?
Correct. And he indicated that there was no evidence of trauma to the neck.
And you reviewed the antemortem photographs at the hospital of Mr. Acevedo, correct?
I did.
And again, that did not show the amount of petechiae in the eyes that you would expect to see if the throat was compressed. Is that true?
Well, there were petechiae over the face and predominantly around the eyes in the soft tissue. And then there were two small petechiae on the inside lining of I believe, the left eye. And this is a pattern that we see where there's congestion, possibly violent vomiting, or compression of the chest and upper abdomen.
So the petechiae you did see might be consistent with chest compression, but not neck compression. Do I understand that correctly?
If I could expound on that.
Please.
The overall pattern of the petechiae were most consistent with chest and upper abdomen congestion. There was petechiae abundantly over the clavicles, the shoulder blades, and the upper, and I'm pointing to that area, Your Honor, over my upper chest, over both the clavicles and down the left arm in kind of a mantle-like distribution. There were also petechiae overlying the face and around the eyes, but very scant petechiae in the conjunctiva or in the larynx and oral cavity.
And the conjunctiva is, again, the eyes, correct?
The inside of the eye, lid.
There's been some other testimony in this case that there was a lateral contusion observed on Mr. Acevedo's neck. Did you make that observation?
I did not.
Was there a lateral contusion on Mr. Acevedo's neck?
No, there was a linear abrasion low on the neck, and I'm pointing to that area over the right side of the lower neck, right lower neck, just above the clavicle. There was a linear scratch.
May I approach, Your Honor?
Yes.
To show you what's been marked as Exhibit 45, Dr. Jensen, do you recognize that photograph?
Yes, this is one of the, exhibit number 45 is one of the photographs taken while in the hospital bed.
Of Mr. Acevedo?
Correct.
Anything more?
Yes.
I'll take that back. Can you sort of describe what is seen here in this photograph? I'm looking at sort of would be the lower right side of Mr. Acevedo's neck by the tube you see there.
Yes.
What do you see?
This is, on close inspection, this is a confluent area of small punctate petechiae. If you look at it, it's a grouping of small, minute hemorrhages about the size of grains of sand, but they've coalesced. And they can also be seen over symmetrically over the top of the left clavicle.
And so, I'm sort of pointing here on the screen, Dr. Jensen, to this sort of somewhat darker area of the skin. You see where I'm pointing?
Correct.
Is a contusion another word for a bruise?
Yes.
Is that a contusion?
No.
What is that?
That's normal skin coloration.
Can you see my finger here pointing along this lateral line here?
Yes, that's what we call a linear abrasion, or it's a scratch.
Not a bruise.
Correct.
And in Dr. Peterson's autopsy report, which you reviewed, Dr. Peterson did not identify any contusions on the neck either, correct?
That's correct, either externally or on internal examination, in which you would expect that there would be hemorrhage in the deep tissues if there was a bruise. And a bruise is basically caused by blunt trauma or some kind of a blow.
And again, that's not present in Mr. Acevedo's neck.
Correct.
Now, based on your review of the materials in the case, do you believe there's medical evidence that Mr. Acevedo's chest or torso were compressed?
Yes.
And describe that for us, please.
Again, there was a pattern of mantle-like distribution of petechial hemorrhages overlying the chest and extending down to the arm. There were petechiae over the facial area, there was, no evidence of cyanosis to the facial area, and that's my recollection.
Okay. And based on what you could see, you reviewed the body camera video as well, right?
Correct.
And based on what you could see in the video, which is Mr. Mattioli sort of straddling, hunched over Mr. Acevedo's back, that appears to perhaps provided some compression?
Yes, there would have been compression of the upper chest and upper abdomen. There also appeared to be actual contusions or bruises to the left, I think the left biceps area in kind of a irregular individual patterns of contusions.
And those contusions, you said on the inner left bicep area,
Yes.
would be consistent with if someone was in a struggle and having their arms grabbed, that might be a cause of a bruise like that.
Yes, we see them with, and I'm just demonstrating my hand, we see that with, if someone were to grab something very forcefully and push on it, would leave a bruise. And you could see the individual finger marks on the body.
Based on your particular expertise, I'll strike that, let me do this first. Based on your review of the materials, were you aware of whether Mr. Acevedo had pre-existing respiratory issues?
That was documented in the medical record, correct.
And what were those issues as you saw them?
He had an immune deficiency, and he had, I guess I would describe it as uncontrolled asthma. He had hospitalizations in the recent past for respiratory insufficiency and pneumonia.
And now, you're not a pulmonologist, correct?
No.
And in fact, once you reviewed the records, you suggested that we contact a pulmonologist to have a more specific expert review those records, correct?
I don't recall that specifically, but I probably would.
And one of the things you reviewed in this case was a report by Dr. James Pearl, correct?
Correct.
Okay. And he was a pulmonologist, correct?
Yes.
Okay. And you would agree with me, or would you agree with me, that as a medical examiner or pathologist, if you come across something in your investigation that's maybe outside of your specific expertise, you should look outside for an expert to look at it?
We consistently will request outside experts in areas of medicine that we're not totally comfortable with.
Okay. And as a pathologist, well, strike that. Based on your knowledge of the respiratory system, your review of the records, your review of Dr. Pearl's report, were you able to tell on your own, or you develop an opinion about the severity of Mr. Acevedo's respiratory disease?
I developed an opinion both in review of Dr. Pearl's report, the medical records, and my own examination of the lungs tissue.
Right. And as part of the materials you reviewed, you were provided slides from the Milwaukee County Medical Examiner's Office of Mr. Acevedo's lung tissue.
That's correct.
And did you review those slides?
I did.
My approach, Your Honor?
Yes. While you do that, Doctor, could you please define antemortem?
Antemortem is an overall term for before death.
Thank you.
And we also use the term perimortem, which is close to or around the time of the dying process.
Thank you, sir.
Dr. Jensen, I'm going to show you what have been marked as exhibits 41, 42, 43, and 44. Just have a look first and tell me if you recognize what those are. Then I'll have you describe.
Yes, I recognize these. These are photographs that I took in my office in Ann Arbor. The first photograph is what I would call a control. This is from a 54-year-old individual.
Let me take that one from you. Published, Your Honor?
Yes.
Move 41 into evidence.
Any objection?
No.
Exhibit 41 is received and marked.
You see that well enough, Doctor?
Yes.
What is this?
This is a small bronchiole inside the lung tissue. On the outside, you can see the big white spaces are where there's supposed to be oxygen and air, and then there's the very thin membranes of the lung tissue. And in the center is a small bronchiole that's lined with what we call epithelial cells or respiratory cells.
This is the areas you expect to see air, is that your testimony?
No. Your Honor, may I approach the...
So, yes, Dr. Jensen, yes, you can get up. Do you want to use the one next to you, actually?
You can see better over here.
It's the same display. Mr. Powell, you had a question?
No.
Okay.
Thank you. And that, again, on the slide of the health users. That's right.
And I also wanted to point out this small linear, you can see them almost elongated cells. That is smoothed up.
I'm going to hand you Department's Exhibit 44. Doctor, do you recognize that photograph?
Yes. We're using photographs for photographs that I took of the microscopic slide with
Those are exhibits 42, 43, and 44. Can I move those into evidence?
Any objection?
No.
Exhibits 42, 43, and 44 are received and marked.
Permission to publish, Your Honor?
Yes.
This is exhibit 44. What is this, Dr. Jensen?
This is one of the airways that Mr. Acevedo's lung slides. And here we can see in the lumen muscle around the bronchus that is the perfect there is thick mucus that is inside the lumen of possibly obstructing the lumen. And then numerous, you can see these small white cells around the lumen. There's numerous mucus cells. There's increased amount of mucus and that would be airflow respirations. This is a pattern of what we call classic severe
And that's would be an obstructed airway? An airway obstructed in some measure? Exhibit 42.
Number 42 is a similar photograph. Mucus inside the lung. Here you can see the large number of mucus cells. Prominent. You can see around the bronchus, which
Lastly, exhibit 43.
And again, similar photograph, but in this one I wanted to highlight the size and number of the smooth muscle cells in the area, and then mucus secreting glands that are
You can take this. Thank you. And again, doctor, what do those microscopic slides tell you about Mr. Acevedo's lungs?
It would confirm, I believe, the report of Dr. Pearl that Mr. Acevedo was medically frail and had severe pulmonary insufficiency.
severe pulmonary insufficiency. How would exacerbation of asthma affect a guy like Mr. Acevedo?
It would, an asthma attack or an exacerbation of asthma causes the bronchi to constrict. That smooth muscle around the bronchi constricts. It impedes the flow of air into the lung, and it impedes the flow of air out of the lung. The amount of mucus that is secreted is also difficult to remove, and that would decrease the amount of air that could get into the lung.
All right, you reviewed a toxicology report from the Milwaukee County Medical Examiner's Office as well?
I did.
And that toxicology report showed cocaine in Mr. Acevedo's system, correct?
Correct. It showed the metabolite or the breakdown product of cocaine.
And you have some training in toxicology, is that right?
I have, yes.
All right. And cocaine, what does cocaine do to the body as it relates to the respiratory system?
Generally, it's described as a stimulant, so it causes contraction of smooth muscle. It causes increased heart rate, high blood pressure, and contraction of smooth muscle organs.
And so when you say contraction of smooth muscle organs, you were showing us on those slides what you said were smooth muscle around the bronchi, is that right?
Correct.
And so would cocaine also constrict those smooth muscles?
Yeah, cocaine is known to cause exacerbation of asthma attacks and decrease, breathing related to the use of cocaine. It also causes coronary artery constriction.
Okay. And you've said that you drafted a report regarding your review of this case file, correct?
I did, yes.
And let's talk briefly about the medical examiner's role in determining cause and manner of death. Cause of death is what from a medical examiner's perspective?
The cause of death is the entity or the incident that resulted in the death.
And manner of death is what?
Manner of death is how the injury or the death occurred.
All right. And so based on your review of all the materials in this case, did you develop an opinion about the cause and manner of death?
I did.
What is that opinion?
My opinion that the cause of death was prone restraint cardiac arrest, and that the manner of death, in my opinion, was indeterminate.
Can you please explain for us the basis for your finding or opinion of prone restraint cardiac arrest? What does that mean?
Could I expound on this
Please.
briefly? Prone restraint has been known to be involved in a number of deaths that have occurred. The research that has been done on prone restraint has indicated that it is an inherently safe practice in healthy individuals. And although a prone restraint, which we're talking about a person who's face down, possibly with their hands behind their back, and possibly with compression or weight on the back, again, is inherently safe, although there is decreased amounts of air that a person can get in, and the compression of the chest and abdomen causes other factors. Although there's a decreased amount of air that gets in, it's compensated by a person breathing more and faster. Recent research in the past couple of years has looked into the cardiac effects of prone restraint. And the cardiac effects are that it decreases the increased pressure on the thorax, and the abdomen causes a decreased amount of blood to return to the heart. So basically all of the blood below the heart that's going to the abdominal organs and the lower extremities is impeded from coming back to the heart. So the heart does not have sufficient blood to pump. It also decreases the amount of air that's coming in, but that can be compensated for. And again, the prone restraint position is inherently safe, but under certain circumstances, it can be sufficient to cause death. And those circumstances, in my opinion, would basically be natural disease, the use of drugs or alcohol, and what I would just describe as violent struggle. So if a person is struggling or encountering some kind of exertive physical activity for a prolonged period of time, that would also play into that, because a person under those circumstances has to utilize 10 times the amount of oxygen that they normally would. So their requirement for oxygenation increases, and that causes what we call a metabolic acidosis, or the acid to build up into the body's tissues, and that also affects how the heart functions. So we now understand that there are cardiac complications of the prone restraint position, in addition to possibly the pulmonary complications. And so the authors in these articles recommend that the term prone restraint cardiac arrest be more descriptive in the cause of those deaths.
So there are factors that increase the workload of the heart, as I understand it, correct?
Correct.
Cocaine use can be one, correct?
Correct.
Physical exertion is another.
Yes.
And regarding, when those things happen, when the heart starts beating faster, there's an increased demand for oxygen, right? That was your testimony?
Yes.
All right. And am I correct that part of what the heart does is pump blood through the lungs, which is where the blood picks up the oxygen?
Correct.
And if lungs are obstructed by mucus or other things, the heart has to put in more effort to get blood through there. Is that accurate?
Somewhat, yes. It's not necessarily just the obstruction of the airways, but it can be an impedance to blood flow to the lungs.
And the harder the heart's working, the more oxygen it needs.
Correct. And in addition, because of the compression on the abdomen and the chest, there's less blood coming up to the heart to pump.
So, based on everything you've seen and based on your opinion, first of all, is that opinion of cause of death to a reasonable degree of medical certainty?
Yes.
Now, let's talk about, you said undetermined was the manner?
Indeterminate. You can tell, in Wisconsin, we used undetermined. In Michigan, I have to use indeterminate.
All right, so quickly just explain the significance of a manner of death conclusion by a medical examiner.
Well, a medical examiner, the statutory responsibilities is to determine the cause and manner of death. And we do that by evaluating the circumstances of the case. We look, in some rare cases, I would say uncommonly, we would do autopsies on probably a third of the cases we examine. And then we also require and do routine toxicology and other types of tests. And by using all that information together, in addition to records and reports from outside individuals, we would make a determination as to the cause of death. And part of that, we would look at the circumstances and the autopsy and all the information we had, and we make a determination on the manner of death.
And what are your options from your perspective as to announcing a manner of death?
In this case or overall?
Overall.
Overall, we have 5. We have homicide, accident, suicide, natural, and undetermined.
And how do you reach a determination of undetermined?
Well, the way I describe it is that you can't make a decision. You can't make a decision between an accident and a suicide, or homicide and an accident, or a natural death and an accident. So in those cases, I reserve the term undetermined. And if you look at medical examiners overall across the country, probably around 2 to 3% of all the cases we investigate end up being undetermined, meaning we can't be sure which specific manner of death to use.
When you say you can't be sure, am I correct that what you mean is the evidence isn't telling you one way or the other to make a decision?
It's not a preponderance either way, correct?
Okay. Can you say, Dr. Jensen, to a reasonable degree of medical certainty whether Joel Acevedo's existing health conditions contributed to his death?
I think in this case, his lung condition was a important component in his death. It would be my opinion that, but for these other conditions, that he most likely would have survived a prone restraint episode.
The one that you saw on the body cameras?
And that was, that I saw and that was described, yes.
And based on the medical evidence that you reviewed?
Correct.
Nothing further for Dr. Jensen.
Thank you. It's about 5 minutes to noon. So we're going to break for lunch. And Dr. Jensen, I'm going to ask you to come back after lunch at 1:30. We'll continue then with Mr. Tiffin and cross-examination. So, ladies and gentlemen, you're being released for lunch. Please, again, leave your notebooks on your chairs. And remember, again, you still can't talk about the case. So hold those discussions until deliberations. And all rise for the jury, please. Everyone else, please take your seats. Anything else for the record, Mr. Tiffin?
No.
Mr. Hart, Mr. Powell?
I have one remark. I don't know that we need to put it on the record, though.
Okay. So I'll meet with attorneys then. We're in recess for lunch. We'll start again at 1:30. Thanks.